This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megura and I'm here with a very interesting case, and this was a puzzle for me intraoperatively, and there's a lot of confusion going on, and let me take you through this case. Now, he's a 45-year-old gentleman who has unilateral white mature cataract since quite some time, maybe an year or so. He doesn't remember of having any trauma to that eye. He said he could have possibly, but he doesn't remember. So at the slit lamp, it looks like just an intermittent cataract. The chamber is slightly shallow. There's no evident phacoemulsification at the slit lamp. It looked to me at the slit lamp as a routine intermittent cataract. Surgery is being done under topical anesthesia. As I prepare myself to perform the incisions, suddenly I notice something unusual. Well, there's a clear gap between the iris and the lens. But this eye has at least 3 clock hours of zonular dehiscence, which was not very evident at the slit lamp. So this caught me by surprise. Looking at this scenario, my mind is thinking about the following challenges. Number 1 is to get the rhexis right. It's going to be slightly challenging because the intermittent lens. Rhexis is the most important step. If I have a rhexis intact, then only I can put in a CTR to support the bag. And let us see how things turn out. Incisions are done. Now, because there is an apparent area of zonular dehiscence, I don't want the dye to get in. So I'll be using only a couple of drops of trypan blue on the anterior capsule so that it doesn't seep across the zonular dehiscence area to behind the lens, which could obscure my visualization. And even when I'm irrigating the dye out, I'm compressing on the incision so that most of the fluid which is there just burps out of the eye rather than get in behind the lens. And as soon as I deepen the chamber becomes unusually deep, and that is some cause for concern. The chamber is pressurized with OVD and I begin my rhexis. The plan is to perform a small initial rhexis, and if tear is under control, maybe I would like to enlarge it in the first go itself. Otherwise, I would like to stop, decompress the bag, and I would make a secondary larger rhexis later on. The rhexis is begun. It seems to be well under control. But as the rhexis nears completion in the area of the zonular weakness, suddenly I feel that the tear is getting out of control and is trying to run towards the equator. At this stage, I stop, keep the flap flat, and then pull it centripetally to rescue it. And of course, the rhexis could be rescued. Although it's eccentric, it is still continuous. Once the rhexis is done, my first goal is to insert the CTR in. I prefer to insert the CTR at the earliest simply because I believe the CTR provides an equatorial stretch to the bag. By this, there is a lesser likelihood of the fluid from the antechamber traversing across the zonular dehiscence and behind the lens, which could potentially cause fluid misdirection and positive pressure. So that's one of the reasons why I would prefer to put in the CTR earlier. A cohesive OVD is placed under the anterior capsule to create some space. Then I'm carefully visualizing that the CTR is negotiated under the rhexis and over the nucleus, and gradually it is threaded in. I'm very cautious in visualizing that the last end of the CTR goes behind the rhexis margin, which is very evident here. So now with the CTR in the bag, I'm very confident that the lens will be very stable and I can proceed with my job. Time to emulsify the nucleus. The superficial epinucleus is first removed, followed by division of the nucleus. I'm going to use the direct chop technique. The tip is buried into the substance of the nucleus and then the chopping maneuvers are done. Since the patient is young and the nucleus is very soft, it's not difficult to divide the nucleus into smaller fragments and then consume them one by one. The first heminucleus is taken care of. Now is the time for the second heminucleus. Carefully but cautiously, the entire nucleus is emulsified. So far, it looks good. Now, as soon as I withdraw my phaco tip, there is a shallowing of the chamber, and lo behold, the entire capsular bag on my left side just folds up and exposing the vacant area beyond the equator of the capsular bag. Well, this was unusual. If that part of the bag was supported by the CTR, which was looking that it has gone into the bag, then it cannot fold up like this. This was confusing. I refill the bag with OVD, remove all the lens matter from the capsular bag and the fornices. Now with the irrigation on, I'm trying to do some hydro polish so that the speckled lens matter which is sticking onto the posterior capsule can be loosened up. There is a suspicion that there could be vitreous prolapse from this area, so I stop, inject diluted triamcinolone acetate into the eye, and I can notice a few vitreous fibrils across the equator of the capsular bag. Please note the chamber is always maintained with the irrigation in my left hand, so I continue to hold with the irrigation in the left hand. I now go in with my vitrectomy cutter. At this point, let me pause because I have two options. One, to either directly go in with the limbal root itself, or to make a fresh incision and go and attack the vitreous from behind. That is, make a fresh praspala incision. In this case, I decide to try out the limbal root itself. Just the idea was to avoid the praspala fresh incision. Let us see whether it works out. So I go in with my cutter, first take care of the initial prolapse vitreous fibril, and then the cutter is placed way beyond the capsular bag margin in the periphery behind the iris. Please note that I am not moving the vitrector at all. It is kept steady and the bevel is turned down. And we can see that the movement which is happening behind the bag, all the oily thing which is there, it's actually the viscoelastic which has entered into the area behind the capsular bag, and that is being cut and aspirated. At every stage, I'm just keeping my vitrector still. I'm not moving around or searching for it, because at this stage I need to be very mindful that my cutter inadvertently doesn't cut the capsular bag nor the iris, because I want an intact capsular bag so that the lens can be fixed in the bag itself. So that's the reason we need to be extremely cautious when you are approaching this route. My plan is, if I'm not successful in clearing off all the vitreous through this route, then I'll make a fresh pars-plana incision and then go from behind. So after a couple of minutes, I feel that there's no more transcapsular bag vitreous which is prolapsing out, and it looks to be alright now. Again, please note that I'm working extremely close to the capsule, and you need to be very careful that you don't end up either chewing off the rhexis margin or the posterior capsule or the equator of the bag. Now with the irrigation in my left hand still, I go in with my cohesive OVD, which is going to create some space, push in OVD under the anterocapsular margin so that the equator of the lens is pushed back. Now, since the patient is a little bit uncomfortable, I go ahead and inject 2 ml of posterior subtenance lignocaine. Now, what's my plan? So at this point, my confusion which is going on is, if the CTR is already in the bag cannot get displaced like this. So I'm wondering whether the initial CTR which I have put, has it slipped out of the bag? Is it possible? So there's a reason why I want to go in and place the ring inside. I want to use an injector, but unfortunately this injectable CTR has the right side opening, which I would have preferred to have the left side opening, which can go and support this bag first, but I got a one which is right side opening. Since the bag was kept formed by the OVD, there isn't much of a stress on the broken area, and I could manage to push in the CTR into the bag. But now I realize that this CTR is shorter for this eye. This was 11 by 13. The patient is myopic. He has got a wide to wide diameter, and it's not supporting the entire circumference of the capsular bag. But nevertheless, because the pupil is so well dilated, I'm going to use a Sinskey hook to engage the eyelet of the CTR and then rotate it so that the part of the zonular dehiscence is well supported by the CTR. In the meanwhile, I have asked my assistant to get a 12 to 14, a larger CTR. I plan to place another CTR inside so that the entire 360 degrees is supported well. This CTR has been pushed appropriately in supporting the bag well. I go in and insert one more CTR so that we have got sort of a double enforcement going on. At this stage, I am still clueless what has happened to the first CTR. I am assuming that it has gone into the sulcus. That's the reason why I am using these extra CTRs. The next CTR is again threaded into the eye, and this is going to support the area quite well. So the bag is very well stabilized now, and now is the time to implant the lens. A multi-piece lens which was originally planned for this case is implanted into the capsular bag. It's ensured that both the haptics are well within the bag and the lens appears to be decently well centered. The OVD both in front and behind the lens is aspirated out. Diluted triamcinolone acetate is used to rule out any vitreous remnant. The eye looks good. The wounds are hydrated. That's it, the case is done. Now these are the first day post-op pictures. There was slight corneal edema. Pressures were slightly higher, around 26. On dilatation, the lens is very well centered, and by 1 week, the eye looks pretty good. The patient has an best corrected visual acuity of 6/6. The pressures are under control. Now going back, I was wondering whether my first CTR has gone in the bag or not. When we go back and have a replay, well, when I introduced the CTR is definitely in the bag, there's no doubt about it. But as it is being threaded, this part I'm not sure whether it is in the bag. Again, when I'm maneuvering the last part of the ring, I can distinctly see that the distal eyelet is also behind the rhexis margin itself. Now this was a puzzle. In spite of these two looking apparently within the bag looked as if it was not supported in the first instance itself. So that was a puzzle for me. So nevertheless, even if it is in the sulcus, the first ring, it should be fine. It will not cause any issue. It's very thin and made up of PMMA, and it's unlikely to cause any irritation to the ciliary body. Obviously, I had to insert 2 rings because the one ring I thought it was not long enough. This was a myopic eye, and so in this situation, it doesn't harm if we go in and place another ring inside. Thank you so much for watching and hope you found this helpful.